introduce?
Yes, please.
Yeah. So,
Show
greetings
me.
and a warm welcome to all the dignitaries present here. I'm Srevshi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the Indian College of
मेरी फोटो
Anesthesiologists,
नहीं आ रही.
and the focus of today's session is anesthetic
नहीं
management
आ रही
of
है.
patient
अभी
with
आप बात करो,
lung
अभी ये बात
abscess
कर रही है
and
इसके लिए।
एक
lobectomy.
मिनट रुके थे.
So let's begin today's session
ये क्या
from
मैं
which
दिखा
I would
पाऊंगा अभी.
like to invite Dr. Bimla Sharma ma'am to take over. Ma'am, over to you.
Thank you, Shresi. A very good evening to you all. And I bring greetings from Sir Gangaram
ये पर
Hospital,
आते हैं.
pain and perioperative anesthesiology, pain and perioperative medicine, and of course, the Indian College of Anesthesiologists. This body, which was founded in 2008, has been conducting online webinars, and without any interruption. We are having it very regularly, and the ICA provides honorary fellowship for senior and eminent anesthesiologists, and also it is running fellowship programs in various subjects in various subspecialties like thoracic anesthesia, cardiac anesthesia, pain and palliative, onco anesthesia, and we are also in collaboration with the ASA and also Samba, and the aim is to provide uniform standard of education across the country. And in this program, we have very eminent speakers. And today we have none other than Dr. R.P. Gedu from Mumbai, who is a senior professor in anesthesia, and he has worked in various capacities, in good centers. He was with the Tata Memorial Hospital, and then later on he joined a private hospital, and he brings with him his vast experience across different subspecialties. And today he is going to talk about anesthetic management of a patient with lung abscess for lobectomy. And this session will be moderated by Dr. Akhil, who is a senior consultant at Sir Gangaram Hospital, and he specializes in thoracic anesthesia and also liver transplantation, and he has
दरवाजा
been
बंद कर.
trained for lung transplantation uh, in Canada. And over to Dr. Gedu.
Thank you, madam. Thank you, Bimba Sharma, madam. I know I respect you a lot. Same thing is true with Manjula Sarkar, who actually made me a part of this. And basically, I have given all this lung anesthesia in Tata Memorial because I was there for 25 plus years. So I'll be starting on this, though I'm talking about lung abscess for lobectomy, but actually it is not for that. Because the thing is, in Tata, I have done all these lobectomies and pneumonectomy also because of cancer. But the thing is, when we are talking of cancer, we have to talk of chemotherapy, radiotherapy, and so many other problems. So it will get extended. So I made it. I have given anesthesia for lung abscess also. So I'll be starting on this lecture. Okay? Can I start?
Yes, sir. Please, sir.
Thank you. Thank you so much, Akhilji. So if you see, this is the first. I will start with a case history where a 45-year-old 60 kg male presented to the hospital with a right-sided chest pain since 5 months, occasional bouts of hemoptysis, and twice in the last month. Dyspnea in the mild exertion, history of smoking also for 20 years, about 20 packs per day, but he stopped about a year back, and posted for right lower lobectomy for the lung abscess because he had a very bad infection. He was having a very bad chest pain and cough and all those things. So what happened is on general examination, what we found, he is febrile, mild pallor, etc. The rest of the things are okay, except the clinical examination of the respiratory system, where we found on auscultation air entry was decreased, and there were a lot of crepes in the right lower zone. more so when the patient sleeps on the left side. So whenever you are sleeping on the left side, the cough or the secretions come and they enter into the what you call respiratory tract, and that is the reason he starts getting cough when he sleeps on the left side. That was the issue with this patient. So preoperative evaluation, of course, is very important, where we do all the CVS and RS, pyrometry and all DLS and all other things. And the anesthesia management will be plan of anesthesia. Of course, we have to see the options of the lung separation, that is DLT, bronchial blockers, etc. And of course, whenever we are doing in bronchial blockers and all those things, there is always associated complicated problems of physiology of one lung anesthesia, which we have to deal. Of course, I'm going to talk about that also. And after the surgery, post-operative analysis and all those complications likely, we are going to discuss about this in details. So if you see what is very important in such patient is pre-operative evaluation, pre-operative preparation. Preparation is also very important. I'll come to that preparation also. Then optimization of the lung function. Thereafter, we will plan for thoracic anesthesia, that is proper conduct and knowledge, and intraoperative monitoring also, and monitoring, and then post-operative. So we, of course, see the patient, detailed history, physical examination, recent investigation, thorough CVS and RS examination, ECG, X-ray, and all those things also. And then, of course, we have to grade the essential ASA grading, whether it is belonging to third or below third. Because if it is more than third, then it is very difficult for you. You have to stabilize the patient beforehand. And important information gained was, of course, we do the spirometry and PFT also. And thereafter, if you find a 50% reduction in FEV1, FVC, MBC, that means more chances of post-operative morbidity and mortality. We have to make sure that in this patient, in case it has got that problem, thereafter we have to give the respiratory therapy also. You have to give the spirometry and plus lung infection, lung antibiotic and secretions releasing things. And thereafter we will find out whether it will improve, and thereafter only we will put patient for the surgery. A reduction in DLCO of more than 50% suggests that there will be adverse outcome in the pulmonary resection. So we have to very much ensure also that we remove the secretions. We do that way, whether we do tapping and we do mucolytic secretions and all those things. And thereafter, we will ensure that DLCO is going to be more than 50%. And then radioisotope also can be done in some hospitals, because in many hospitals it's not been available, though in Tata Memorial Hospital it is available. Now, aims and the preoperative evaluation is, even if the patient is posted for lobectomy, one must assess and be prepared for pneumonectomy, because you never know, it can be extended also. So when the surgeon opens the chest and then he says, oh my God, it is not only lower lobe, it may be infected on the middle lobe or upper lobe also. So in that condition, they may have to go for a pneumonectomy also. So what investigation will you ask for? So we have to do for a cardiac function evaluation, respiratory function, lung mechanic evaluation, lung parenchymal evaluation, and CPET. CPET, of course, is not available in many places, but in some places it is definitely available. So what are the patient's characteristic we have to see? Patient's advanced age, is it there? Or then smoking habits, as I told you already, patient was smoking 20 packs per year. And nutritional status also, what is his nutritional status? And what are the coexistence of the diseases, whether he is in a bronchospasm or there is a hypersecretions also there. That's the reason he is unable to do. And the surgical site, whether it is upper abdomen, thoracic, surgical procedure, then lack of preoperative preparation, whether it is the emergency surgery or not, and the type of anesthesia and duration of the surgery operation. And thereafter, we will decide whether it is more than 3-4 hours. That means patient can likely to go into a lot of complications also. So what pulmonary function test will do? There are types of 3 phases of the pulmonary function. One is a total lung function, split lung function, and invasive preoperative balloon pulmonary artery occlusion. But this is not being done many places, rarely needed, but it is done in our Tata Memorial Hospital also. So phase 1, total lung function, we have to just ensure that FEV1 and all those things are less than 50% and all, and arterial PaCO2 is more than 46. This all indicates that patient can land into post-operative respiratory insufficiency. So we have to ensure that these things are being improved by either giving antibiotic, mucolytic, and chest physiotherapy. Thereafter, we will try to see whether he is been able to improve his function or not. And non-invasive technique, of course, radioisotope pyrometry and perfusion scanning is also been done, as you can make out from his lungs also. As I'm pointing out over here, see this lung is not showing very well. This lung is showing very well, and so preoperative FEV1 into the percent perfusion of the non-operative lung, plus so many things are to be ensured, and that will predict postoperative FEV1 needed is for the survival. At least it should be more than 800 to 1 liter minimum. That is for sure. So quantitative lung function test is normal. Patients has got right lung is 55%, left lung is 45% lung function, because right lung has got 10 bronchopulmonary segments, and that's the reason the lungs are more, while the left lung is 9 segments, so it is 45% lung function. Of course, genome scintigraphy also can be done, but that is not been available in many places. But what we make it sure is expiratory function loss is important, because if you see preoperative FEV1 into the percent of the lung function affected, and thereafter we will find out whether number of segments to be resected are more, and what are the total number of segments. As I told you, total 19. So how many you are going to remove, whether we are going to remove 3, 5, or whatever it is. Because if it's right-sided, then it's 10 segments are removed, while if it is left-sided, it is 9 segments are removed. So total 19. So that will have to make it sure. So how much it is going to do? So if you see, this is a normal, if you're planning for a lung resection, normal MVB is 75, FEV1 is more than 2, FEV1 is 25 to 75% is more than 2. While if I'm planning for a pneumonectomy, it should be more than 55, more than 2, and all those things. And lobectomy, it should be more than 40 MVB predicted, and more than 1 FEV1 and all those things. Wedge registration is done, is more than 35 and all those things. And if patient is inoperable, of course, in such a condition, that means your MVB is less than 35%, FEV1 is less than 0.6, and FEV1 25 to 75% is also less than 6. So in such a condition, patient is not being operable. So one has to make it sure that whether all these things are being available and all these facilities are available or not, and then we will make it sure whether you can go for a pneumonectomy, lobectomy, or wedge resection. Same thing happens if it is post-operative FEV1 and DLCO values also we have to check based on the function of the sub-segments to be removed. That means, as I told you, whether I'm going to remove your 3 segments, 5 segments, 8 segments, whatever it is. So total bronchopulmonary segments, as I already told you, 19. Out of that, right upper lobe is 3, middle 2, left lower lobe is 5, while left lung is upper 3, lingual 2, and lower is 5. So it is 19 total. So predicted post-operative DLCO is pre-operative DLCO into 19 minus the segments to be removed upon 19. So what is acceptable value? If it is more than 40%, then it is worth going for a surgery. While another thing is, if it is predicted post-operative FEV1 is, if predicted pre-operative FEV1 and more than 19 and also if it is acceptable figure, if it is more than 0.8, in that condition only patient can be worth surgery, and his recovery will also be much more better post-operatively. So a preoperative FEV1 of more than 1.5 liter for lobectomy and more than 2 liters for pneumonectomy generally indicates suitability for the patient to be operated. So if VO2 testing is not available, then how will you evaluate? There are many things, because in many institutes, because I told you, in Tata Memorial, we do have VO2, but in many hospitals and all those things, these things are not available. So the best thing is simple things, that is clinical testing also can be done, whereby I can tell the patient to walk, to step up, step down, and all those things, and thereafter we will decide how much it is there. So these are the things. So that is what we call simple interesting tests are walk test, stair climbing, that will evaluate the functional status, monitor the treatment effectiveness, and establish the prognosis. And then, of course, time based, that means 2 minutes, 5 minutes, 9 minutes, 12-minute walk. So if you are walking 12 minutes and thereafter if you are feeling breathless, that means you are not fit for surgery. But if you are walking 12 minutes, of course, I can say before you started walk, your respiratory rate was, let's say, 12, 15. But now after 12 minutes walk, it may be just 15 to 18 to 20, but that doesn't mean I am very much breathless. And if I'm breathless, then that means I'm not worth for surgery. I may have to go for physiotherapy, lung testing, and tapping, and mucolytic secretions, antibiotics, and thereafter we make it sure whether patient's walk test is much more better or not. Same thing is fixed distance tests. That means 100 meters, half mile, 2 kilometer walk test. That also can be done. So many times, if it is other functions are not available, these simple things can be also done insured. So the advantage of this is it needs less technical expertise and equipment. It is inexpensive, easy to administer, employ an activity performed daily by the patient. So that is very important for us. So many times they always say that if my operation theater is on the third floor, I will tell the patient from ground to third floor, walk. And before you walk, I will just ensure whether your breath test is how much. Like for example, if you are 12 to 15 and when you're walking 3 floor up, and then I'll make it something like 25, 30 and you're breathless, that means you're not fit. So I'll have to give so many other things, antibiotic and all those things. And thereafter, maybe another week, 15 days or 1 month. And thereafter, I will see that whether you are improved. And thereafter only we can make out whether you are fit for the surgery or not. So these are stair climbing tests that was being done. So many authors have done, like Olson, Horton. They have said 54 patients where they have said more than 3 flights is acceptable risk, more than 44 steps is acceptable risk, more than 2 flights is acceptable. So many things are there. So exercise desaturation is also important. So and exercise oxygen desaturation. So what we do before you start exercise, I will put you pulse oximeter and let me see your pulse oximeter. That time is showing 94, 95. And now you walked 3 floor up and now it comes down to maybe less than 90. That means you are not really fit for the surgery. I will have to improve your lung function test and thereafter only I will ensure that your lung function test and all those things are okay. So you can undergo your surgery. So these are the overall steps that are being taken over. If you can see average risk, can you see this over here? Average risk, increased risk, high risk. So if it is average risk is there, that means if your FEV1 is more than 2 for pneumonectomy, FEV1 is 1.5 for lobectomy, more than 80% is normal, or DLSO is more than 80% predicted. While increased risk is this, and high risk is if your VO2 is more than this 20 ml per kilometer and all those things. So these are the things which will show that whether patient is really worth for surgery or not. Not necessary, I will go for DLCO. I'll not necessarily, I'll go for any interventional things. So let's summarize the distribution of the ventilation and perfusion. So if you see, this is the total one, what we see, a special consideration for respiratory physiological changes in ventilation and perfusion of the lungs is in relation with lateral, because when the patient is getting operated, so that means if I'm going to do your right lobectomy, of course, I'm going to put you on the left side. That means your right one is up. So in such condition, lateral decubitus is under GA control ventilation open chest, and you can see over here, you can see how much functions it will differ one lung and changes in the blood flow. So naturally, the lower one, that is, if I am putting you on the right side is up, that means the blood flow will be more on the lower limb, that is the left side, while right side will be less. Same thing is reverse. The air will be more on the upper one, the air will be lesser on the lower one. So that is also important. If you see upright and lateral position, as you can make out over here, so this is your normal one lung and this is your lateral one when we are doing. While reverse is the true for the gases, and you can see in the dependent lung only the decreased ventilation while blood flow and all those things are increased. So end result is hypoxemia. So that one has to make it sure. So this is what we call hypoxic pulmonary ventilation. That means adaptive vasomotor response to the alveolar hypoxia, active process of vasoconstriction of a small muscular resistance and all those things. Then HPV increases PVR by 50 to 300%. Onset is in 3 minutes and maximum is in 15 minutes. Can be sustained for hours, not attenuated by repeated hypoxic challenges. So hypoxic pulmonary ventilation is a normal procedure. It is not a pathological procedure. So whenever I'm going to put you on the lateral position, naturally hypoxic pulmonary ventilation is going to occur. But only thing, if your lung functions are both are very good, then in that condition it will not be very much problematic. So if you see over here also how it direct AC, if you see this lung over here, so this is hypoxic type of things while this is normal one. So here I can see direct inhibition, volatile anesthetic also, not nitrous, but vasodilator, like if I'm using NTG, sodium nitroprusside, dobutamine and all those things, or if I'm having an increased PVR because a patient is having also mitral stenosis, mitral incompetence, pulmonary embolisms and all those things, or hypocapnia. Or there are indirect inhibition because if I find the patient saturation was lower, so I started giving you PEEP. So that means naturally it will affect the HPV more. Same thing happens if I'm patient's BP is less and I start giving vasopressor. Naturally, the blood flow, blood vessels become normal. I mean, blood vessels become constricted. So that is the reason there will be a lot of hormones of lung vessels will also become what you call the vasopressors will constrict the lung vessels also. So naturally, the flow of the lungs will be also less. So naturally, the saturation will also drop for that reason. So in such condition, let's come back to the patient. So what are the investigation patient had? Patient had hemoglobin was okay, WC, everything was okay. So predicted preoperative, the postoperative FEV1 was 55%. Predicted dual CO was 48%. 2D echo was also showing normal with a ejection fraction of 55%. ABG was also okay, except POCO2 was a little more, 46, and PO2 normal with air was for 65%. So is this patient fit for lobectomy? Yes. How will you optimize this patient? But we have to still optimize the patient a little more so that patient can have a better outcome. So how we are going to optimize? So I will always tell the patient smoking is cessation. So it should be minimum 8 weeks. If you are smoking, stop it for 8 weeks. So that reduces your sputum production, airway reactivity, and increases the sputum clearance. 12 hours can reduce the carbon monoxide hemoglobin level also. Dilatation of air, that means I will start using inhalation of the beta agonist, theophylline and all those things so that the airways will be dilated, as well as I will give for loosening the secretion, I will start giving mucolytics. I will start giving more hydration so that everything is being ensured. The removal of the secretion, that is postural drainage, if it is possible, I will do. Like if I have got a lung abscess on the right of lower lobe, I'll put you on the left side, and thereafter I'll just tap on the a little head lobe and tap on your lower side, lower lung on the right side, so that the secretion, postural drainage will come. Patient may cough, but at least secretion will come out, so that will help for the future. That means that will definitely increase the patient's outcome in the next one. Of course, I'll ensure breathing exercises and motivation and education of the patient, and incentive spirometry will also help a lot. What exactly is smoking? There are a lot of things that are being discussed on the smoking and duration. So if I see, if you are smoking stop 4 to 6 hours, the nicotine levels will decrease. 12 hours carboxy hemoglobin will also decrease. But if I go down also, something like 2 to 6 weeks sputum volume will decrease, and 3 month tracheobronchial secretion and clearance will be more, and more than 6 months, of course, not only tracheobronchial clearance, but also your immune level will also increase. So that will also help us for the patient's progress in the next post-operatively also. So now let's plan the anesthesia also, what exactly we are going to do. That is basically thoracic epidural anesthesia plus GA. So that will ensure an excellent analgesia with epidural, a reduced requirement of the muscle relaxant, and lower risk of hypotension. Post-operative analgesia will also be ensured, may felicitate early ambulation, better performance for the respiratory therapy, may reduce the post-operative pulmonary compression and all those things. So how we are going to go one lung anesthesia? That is very important. One lung ventilation means separation of the two lungs and each lung functioning independently. So it is intentional collapse of the lung on the operative side that and which facilitates most of the thoracic problem. Requires much skill and experience of anesthesia team because difficult to place the lung isolation equipment. One has to be very well trained for the one lung anesthesia. Ability to overcome the hypoxic pulmonary vasoconstriction. Patient's population is comparatively sicker, and significant physiological changes, etc., should be also mentioned very much. So absolute indication for one lung anesthesia is very important. Isolation of the one lung from other to avoid spillage or contamination. That means infection, massive hemorrhage, control and the distribution of the ventilation. That means bronchopleural plus minus cutaneous fistula, because that can happen anytime. For example, if a person is already been stabbed, that means you have got already cutaneous fistula. Surgical opening of the major conduct airways. So when the surgeon opens, that means it may go to the other side also. Giant unilateral lung cyst or bulla, And tracheobronchial tree disruption can also occur, and lung-threatening hypoxia due to unilateral lung disease also is there. So one must ensure a unilateral bronchopulmonary lavage has to be done. So what exactly we do? Surgical exposure, high priority. So we ensure that patient doesn't have thoracic aortic aneurysm, and we see that he doesn't have any pneumonectomy, upper lobectomy, and all those things. And these all things are very important for us to make out. Now, one lung anesthesia, how we are going to plan. So there are multiple techniques. One, you can use a double lumen tube, where you can use a Portex one double lumen tube, right and left, or Robert Shaw double lumen tubes also. Or we can also use an endobronchial blocker, so that single lumen endobronchial blocker, ATT, with a built-in bronchial blocker, that is Univent, or single lumen tube with an isolated blocker, aren't bronchial blocker. Then Kuptek also bronchial blocker. I'll show you in the next slide also. And then balloon tipped luminar also. And single lumen endobronchial intubation also can be done in case patient is fairly good at planning. The surgeon says that I may have to go for a pneumonectomy also, and the patient is having very good respiratory function and all those things. In such condition, I may have to go for a single lumen endobronchial intubation as well, so that the other lung is not getting ventilated at all. So these are the double lumen tubes that are being available. So this is what you see, Univent bronchial blocker. So this is what Univent blocker will go, and this is right-sided and left-sided endobronchial tube, endotracheal tube. This aren't one, where you can see which one it will be guided from here only, so that in multiple port, so it can be guided. Or of course, the newer ones have also come out. That of course this is one Rush bronchial blocker also, which can be just placed whichever side we want. Or this is EZ blockers, which is newly available. But only problem with this EZ blocker, though it will be fairly popular, but still the problem is it has been found that it basically blocks the either right or left. So sometimes if I want your right upper lobe also to be ventilated, because the blocker will be placed, I may not be able to ventilate your right upper lobe also. So that is a problem, but otherwise easy blocker is much more easier to crack. Then Kuptek is also there, and then this is what easy blockers and all can show like this. So if you see easy blocker, it is blocked once. So even if I want to ventilate your right upper lobe or left upper lobe, I will not be able to do that. Then there are Cohen flexitip, which is, I mean, I'll just put the endotracheal tube, and thereafter I'll just put this, and this is rotation. Here, there is a rotator over here. So I will rotate it so that once it enters in your this lung trachea, I will rotate it, whether I want to place it right lower lobe, left lower lobe, or whatever it is. It can be rotated like that. Then there is also, this is the latest one that has come up, that is called Viva Site endobronchial blocker, which has got the best is we don't need a what we call imaging technique or any other techniques. See, this is one which has got, once it is high resolution video, imaging camera is there. So whenever it is being placed, it will place it exactly wherever it is placed. I can just make it on from the camera. I don't have to use any fleximeters and all those things. So of course, pediatric size is also available, which can be used also. But in pediatric, many times it is very difficult for us to put an endobronchial intubation. So under 2 years, it is very difficult. So I may have to use it conventional endotracheal tube. 2 to 6 years, I may use ARNT blockers. 6 to 10 years also ARNT blocker and all those things can be used. Or if you are more than 10-year-old, I can use DLT also. So this is the ideal placement, as you can make out. Whenever I'm placing, I must ensure that it is placed correctly so that I'll be able to ventilate your right upper lobe also whenever I want. Unless I'm going to do your surgery, that's it, then only I will stop it. Same thing on the left side also, it can do like that. Malpositioning of the DLT is very possible. There is, so whenever it is malpositioned, it has not been properly positioned, then in case you will find increased resistance to ventilate, there is increased chances of leak and aspiration, increased chances of hypoxemia, increased chances of CO2 buildup, subsequent tachycardia and hypertension because CO2 is being built up, and there is increased chances of bleeding because your CO2 is built up and tachycardia is there. There is chances of plus minus cyanosis, high peak pressure, and then of course surgeon will not be also very happy inconvenienced for the surgery because your lung is unnecessarily being collapsed. because it is not being positioned properly. How do you do a common placement and all? Clinically, by clamping, unclamping, and auscultation technique. Is there any leak or cross ventilation also? Underwater seal. Radiological confirmation is also very important. We can make out that also. Or fiber optic bronchoscopy plays a very important role, but many times in many other small hospitals or something like that, fiber optic scope is may or may not be available. So that in such condition, what we will do? This is what is very important. What we have done. Uh, Left double lumen tube are believed to be correctly positioned on clinical assessment, but there are 20 to 48% chances of malposition if you auscult. Because whenever I'm ausculting just near the sternum on either side, I may get ventilation from the other side. So there will be 20 to 40% chances that I may be malpositioned, but I'm getting auscultation. So that is very important. Of course, the things that are, this is what you say fiber optic. When I put a fiber optic, I can make out whether my tube is correctly placed or not, or left sided tube also, right sided tube also. But this is the latest one that has come up, ultrasound guided, because this is what we have done in Tata Memorial Hospital. We have done, in fact, I don't remember till I retired, there were two candidates who have done dissertation also on USG guided one. So if you see, this is what we call it as lung pulse sign for a collapsed lung. So when it is collapsed lung, you will get a pulsation coming from the heart. While if it is ventilated lung slide, because it will be sliding from the percutaneous to the, or I mean, from the pleural level to the lungs. So it will be ventilated lung. So this is very important for us to know whether your lung is collapsed, so that you are getting a lung pulse sign, whether it is ventilated, so there is a lung slide. So your lung and this pleura is been moving. So a thorough knowledge is very important. So one must know physiology of the one lung ventilation, variety of the double lumen, and all those things also. And if these are the things which are needed, stop smoking if possible 4 to 6 weeks, or at least 5 to 7 days before the surgery. Use bronchodilator and nebulizer to reduce the cough and sputum. Use mucolytic to ease the secretions. Use proper antibiotic therapy to reduce the infection. Start IPBB and physiotherapy and all those things. Maintain the adequate nutrition and hydration status. So assess the overall cardiorespiratory function status and all those things. Now come to the GA. So what are the advantages? GA, it is the best choice for thoracotomy patient. Advantage of GA is, of course, a quiet patient with a still operative field, a quiet onset of the analgesia, adequate muscle relaxation. So surgeons are also very happy. So there is a very much, surgeon will say that, oh my God, I'm not having any problem on your operating side, so I'm very happy. So this is very important for us to know whether we are having GA or not. But ensure proper pre-oxygenation before GA. Ensure a smooth induction and adequate muscle relaxation. Ensure proper placement of the double lumen tubes. As I told you, there are many things you can do: dual lung capnography, fiber optic bronchoscopy, or even ultrasonography and all those things. If needed, insufflate low flow oxygen into the isolated lung, and because as long as possible till the surgeon opens, and once surgeon opens and now he says, oh yes, I'm going to now remove the lung, so please stop surgery. I mean, stop ventilation. That time I will stop the ventilation. That is very important. As long as possible, I will ventilate both the lungs till the surgeon really says. Ensure proper positioning of the thoracotomy procedure and all those things. Usually standard technique of GA, induction and all those things, as you know, IV ketamine, propofol, whatever you want to give. Intubation is DLT or bronchial blocker. Best thing is, and even if you put DLT or bronchial blocker, ensure it is correctly placed with a fiber optic bronchoscopy. Then maintenance with halothane, isoflurane, and air oxygen. Fentanyl, propofol infusion also can be given. A proper monitoring, fluid therapy, and suctioning is important. Proper reversal and extubation at the end of the surgery also plays a very important role. Maintain too long ventilation as long as possible, as I told you earlier, till the surgeon says, yes, now I have already reaching the site of the surgery. That time I will stop the ventilation of the surgical site lung Till then, otherwise I'll ventilate. Then I'll use FiO2 of 1, tidal volume of 10 ml per kg, adjust the respiratory rate, increase by 20 to 30%. No PEEP, because whenever you are doing PEEP, it will increase the problem with all those things. Continuous monitoring of the oxygenation of ventilation is important so that you can ventilate and you can ensure that SpO2, ABG, and all those things are being maintained. And before shifting to one lung, check tube position by fiber optic scope. Because even if I have put you a double lumen tube when I am putting you on supine position, but when I turn you one lateral side, that time the the tube may move here and there. So in such condition, whenever you are positioned also properly, I will make sure that I'll do fiber optic SOP so that I will ensure that it is being properly placed that time also. In case of hypoxia or fall this saturation occurs, so I will increase the high FiO2 first line therapy, tidal volume 8 to 12 ml per kg to prevent atelectasis. If airway pressure is high, then reduce the tidal volume and increase the respiratory rate. CPAP to add the operative lung, PEEP to add the ventilated lung. If needed, high flow jet ventilation 10 to 12 per square feet at inch to the operated lung. Ipsilateral pulmonary artery clamping also can be done. This is very important because sometimes whenever I'm going to operate you, because the thing is, for example, if the surgeon starts operating on your right lung, now he says, yes, I'm going to now remove the right lower lobe or whatever it is. In that condition, I have to ensure that pulmonary artery clamping is done on the right side so that there will be no blood flow over there. That's the reason, because there is no, blood flow will be there, but still there is no oxygenation there. So naturally it will cause hypoxia. So I'll just do the clamping till the surgery is being done. Once the lobectomy is being done, I will tell them to remove the clamp so that the lungs and the ventilation and the blood flow will be ensured correctly. Reinflate the non-ventilated lung if needed. Monitoring are many. Normal, of course, on the left side, you can see basic monitoring, heart rate, and all those things. While advanced monitoring, invasive blood pressure, CVP, PAP, pre-cordial Doppler, respiratory and BIS, and all those things. But many places, this is not being available. Now, in case of any problem that occurs, air leak from the side of incision, common complication is very much common. There is increased secretion in the normal or diseased lung. There is increase in the airway resistance, so it will lead to the spasm, kinking, pulmonary edema, a recurrent laryngeal nerve injury. Intraoperative hypoxia is very common. Bleeding can occur, surgical instrument or hemorrhage. Pneumothorax can also occur, particularly if the surgeon is been operating on tracheobronchial tree also. There is a chances of, because of this, there will be chances of arrhythmia and hypotension. Cardiac tamponade also can occur, or even chylothorax can occur. Because when I'm operating, or maybe I have done the cutting of the chyle also. What about the predicted post-operative plan using the predictive post-operative FEV1 is FEV1 if more than 40%, extubate the patient in the operation theater only if the patient is alert, warm, and comfortable. While if it is predictive post-operative FEV1 is 40 to 30 or 30 to 20, you have to ensure that patient is been not extubated and he is put on the ventilation. How to manage the recovery? Sitting up, propped up position, head up position, and thereafter humidification will be given for the oxygen supplementation. Monitoring all those things, watch for vital signs and all those things. Incentive spirometry to be ensured. Tell the patient to have a coughing and breathing exercises also. Bronchodilate or mucodilate if it is needed. Steroids, SOS, it can be given. And of course, since I have given you thoracic epidural, pain relief will be also ensured, because once you got a pain relief, naturally you don't have a much more pain in the thorax. So naturally, patient will be breathing much more better than no thoracic epidural. So if thoracic epidural is put, then ensure that patient control epidural analgesia has been given, or intermittent boluses also can be given. So it can be given as a local anesthetic plus minus opioid also can be given. You can add morphine, buprenorphine, fentanyl, whatever we can add. IV opiates also can be given if it is epidural not being used. Intercostal nerve blocks and paravertebral blocks are being used intraoperative. You can tell the surgeons also to do that. And pleural catheter, not so popular, it is not being done. Then IV analgesia for rescue, paracetamol and all those things also can be done. Important to keep the patient pain-free so as to prevent the post-operative pulmonary complication and delayed recovery. So take-home message is a thorough knowledge of physiology and pathophysiological of the respiratory disease is important. A complete preoperative assessment plays a vital role. Lung function testing is done in a stepwise manner, allows prediction of the operability as well as the likelihood of post-operative complication. Confirmation of DLT is must before starting the surgery. Reconfirmation must follow for any after changes also. Each method has its own disadvantage, so combination method to address individual things are very important. Thank you very much. Yes, Akhil.
Thank you, sir, for such an elaborate and a comprehensive coverage of the topic. So you've covered everything. So I would just like to add a few things on this for the postgraduates and the for those point of view, that most of these patients who can come for lobectomy or for lung abscess, they can present to the emergency ward sometimes because they get a rupture and they develop a bronchopleural fistula or sometimes a pneumothorax. So
Please
I would just like
unshare
to.
your screen. Please
Huh?
unshare your screen.
Dr. Gedu, can you please unshare your screen?
Which one? The presentation?
Yeah, the
Yes,
presentation. Yes, sir.
yes,
Yes, sir.
yes, presentation.
I don't know how it is going to enlarge.
So you have to just have to press the stop share button on the top.
Yeah, now it has come. You are looking bigger. I'm looking
No,
smaller.
it's
Don't
not
worry.
unshared yet.
You are also
It's
looking
not.
bigger. Manjula with grandchild.
It has not stopped sharing. So I think we can discuss. So
Okay.
most of the time they can present in the emergency with a lot of chest pain and cough with a pneumothorax. So for the postgraduate point of view, they should be knowing about the triangle of safety from where we insert our chest tubes. So it is present in the mid axillary line, posterior to the posterior border of the pectoralis major and the anterior border of the latissimus dorsi. We insert it normally in the fourth and the fifth spaces. So these patients, they are very tricky at that moment of time. So sometimes if you're suspecting a pneumothorax, we can also do a needle puncture in the second intercostal space so that the immediately the pain can be relieved and the distress can be relieved for the patient. So I think that is very important for the postgraduates.
I still remember I had given anesthesia for a patient who was being stabbed in the chest with your
Yeah.
trachea and bronchus all being stabbed. So
Yeah.
naturally you were in a very bad status in the casualty. I have
Yeah.
given that also. I have given anesthesia for the tracheal dissections also.
Yes, sir. And patients with lung abscess, they can sometimes even have a lot of hemoptysis because of the erosion of the bronchial arteries. So these patients might even present with a low hemoglobin or they are coughing and there's a lot of hemoptysis. So at that moment of time, if the patient is coming into the emergency, so I feel that we should keep all those patients with the dependent side down, on the side of the infection down, so that the blood or the
That's
secretions
what I
which are
said. We have to
coming.
go to keep on tapping all those
Yeah,
things
tap in.
chest and then
Yes, sir.
give the mucolytics and antibiotics so that
Yes,
it
sir.
is being ensured that your things are secretions are or the blood and everything is being coming out properly.
Yeah. So that is very important. And if we have some time, so we can even go in for an intervention radiology guided the embolization of the bronchial artery if the patients are going for a massive hemoptysis. See, the other thing, sir, I would just like to ask, sir, do you normally prefer an endobronchial intubation? What do you think is the gold standard? At our institute, we feel that the placement of a double lumen tube is the gold standard because from the other lumen, we can continuously do a suction and we can aspirate all the secretions. Because once we had a case, we were unable to put in a DLT and we put in an endobronchial tube. So when the lobectomy was done, all the secretions got pulled up in the mainstem bronchus. So when you take out the tube, the secretions can go and they can soil the normal lung, and even there is a difficulty in
What I'm
ventilation of the
trying to tell
patient.
you that whenever the patient was having a stab on your chest, right side or whatever it is, and
Yes,
your
sir.
bronchus and all those being stabbed, so in
Yes,
such
sir.
condition, I will prefer to put an endobronchial intubation only on your opposite side, that is left side,
Yes,
because
sir.
anyway your right side is not going to function at all because it has been stabbed. So naturally, there is a lot of air that is coming from the atmosphere and all those things. So that is the reason we prefer to go endobronchial. Otherwise, we prefer to go for a double lumen tube only naturally, and we can stop whatever it is. Only thing, it depends whether you are being stabbed or not.
One more thing, like in patients who are having a lung abscess and they're coughing out a lot of secretions and pus. So, what is your take on doing a rapid sequence intubation without ventilation so that there are no chances of spillage of the contaminant from to the opposite side? Because if we are the moment we give a relaxant to the patient and we are ventilating, there are chances that when the secretions they come back into the trachea, they can go on to the opposite side. So if we do an RSI and if we don't ventilate and we are able to secure the DLT in the first place, so what is your take on that, sir?
No, as I told you, of course, if you got a secretions and all those things, naturally, I will not give you anesthesia immediately. I will prefer to make your secretions and all those things become low by giving antibiotic, mucolytic and all. But still, if it is an emergency, naturally, as you rightly said, it is very difficult for us to put an endobronchial intubation and all those things also. But it can be done RSI as fast as possible.
Yes, sir.
But again, it is to be ensured, even if you have done RSI, you have to ensure that whichever, for example, if you got a lung abscess on right side and you are being secretion like anything, and now I put a double lumen tube also, I'll ensure that on my left side, I'll put a suction, and see that the pus and all those things are not come out from there, pus,
Yes.
blood or whatever it is. I'll
Yes.
ensure that.
Can
And
I
sir,
ask something, sir?
yes,
Yes.
yes, sir.
Okay, sir. I just want to know, in case of bronchial hemorrhage occurs during the procedure, how you are going to prevent it and what you should do it at that moment if bronchial hemorrhage occurs.
Madam, as I told you already, bronchial hemorrhage, if it is going to occur also, I will tell the surgeons to put a bronchial blocker. So the bronchial blocker is
But
there.
if you don't have the bronchial blocker, then
It is just a clamp, madam. They put it on the bronchial.
they just a clamp, surgical clamp. You mean
It
to
is
say
not surgical clamp. It can be removed once the bleeding is being stopped, or once your hypoxia is being stopped. So it is just a
Okay.
blocker, means it is not a permanent blocker. It is just a clamp.
Okay. And one more thing, I just want to know, in case of the lung abscess is near hilar area, so can we do the tube and through the endoscope?
Yeah, you are right.
We can do it?
Yes.
Okay. Okay, Dr. Akhil, you can carry on.
The other thing which I would like to just discuss that sir said, sir, do
And
you
you are from
routinely?
Gangaram.
Yes, sir.
Oh, Pradeep Jain, you know.
Yes, sir.
Oh, he's a very good friend.
Yes, sir.
There was one, remember his name, who's senior, who's retired from there.
Dr. Pradeep Jain. Yes, he just retired around about 2 months ago.
Oh, Pradeep Jain also retired.
Yes, sir.
Oh,
Yes, sir.
I didn't know that. Oh.
Yes, sir. And sir, as you mentioned that the tidal volume which you like to give is 8 to 10 ml per kg body weight. But right now, if we see that the focus has now shifted, or there are a lot of studies which say that we should go in for 4 to 6 ml per kg body weight with an increasing respiratory rate and a titratable PEEP, because to see the inter-individual variations which are happening in a lot of patients.
What I am trying to tell you is, when I am going to block your one lung,
yes, sir.
In that condition, the other lungs should not go into hypoxia and all those things. That's the reason. Initially, when I am giving you 5 to 6 ml also, now if I will try to increase it to 8 to 10 ml, so that I will ensure that more oxygenation is being given to your ventilated lung.
Yes. True, sir.
But sir, Dr. Akhil, as Dr. Akhil is saying that low tidal volume and high respiratory rate is the ventilator strategy at present in these kind of the cases. So what is your opinion regarding this?
Low tidal volume and high respiratory rate doesn't increase your saturation, or it doesn't increase your oxygenation. Naturally, you'll have to increase, because the thing is, you are also adding not only oxygen, there is a small amount of nitrous also is being added over there. So naturally, I will increase the tidal volume also more, and respiratory rate also more, so that your respiratory rate is increased and your saturation will increase, which was below 85%, which will now come to 90+%.
But nowadays we have the good ventilators with us in which we can do the these kind of the ventilator strategies changes, and that is going to benefit the patient if we maintain the on ABG. It is advisable to do that.
Yes.
Like Dr. Gedu, sorry if I like you add CPAP to the other lung, no? So that is also one of the strategies they practice
Correct,
more often
correct.
rather than increasing the tidal volume. That's
There is now a new concept of which is known as a lung opening pressure, lung opening pressure maneuvers, in which on the dependent lung which you are ventilating, you can ventilate that the lung for 10 to 15 seconds with a pressure of 30 to 40 centimeters of water, and then you can apply the PEEP, so that in the general anesthesia, the all the areas which have gotten atelectated, they will open up, and we are able to prevent the atelectatic trauma and the volume trauma and the biotrauma. So we are now focusing on the driving pressure, which is the difference of the pressure between the plateau pressure and the PEEP. So that pressure should be somewhere around 25, should be more than 15. So the peak airway pressure does not really signify, because there are two modes in which we are using, the volume control or the pressure control. Both the modes can be used till the time the pressure we are giving to the dependent lung, it should not increase to more than 25. So, but that has as the most common reason for a post-operative the pulmonary edema or the acute lung injury which is happening. And so, what would be your take on the fluid management of these patients? So, do you normally go in for a restrictive restrictive fluid strategy, or a liberal one, or a goal-directed one?
No, it will be restricted only, because the thing is, if you give more, there is a chance of pulmonary edema quite high.
Yes,
You have to be very careful, because your one lung is not being getting ventilated.
yes. And nowadays, if we insert an arterial catheter, and
Yeah.
in the arterials, in the all the monitors, we
Yes.
get a pulse pressure variation without any specific
Correct.
cardiac monitor like a Lidco
Correct.
or a Edwards.
Correct.
So, yes, sir. I think we should, if somebody else wants to add something more. So we have discussed most of the aspects of the topic.
I hope you were
Dr.
happy.
Gedu, what about the post-operative management? Like your experience, like you prefer the epidurals?
Yes, madam.
For
We put a thoracic epidural only. And once we put a thoracic epidural, we can give a local anesthetic along with a narcotic also. And it can be given into the infusion system also, or intermittently also. We can do that also.
What about the paravertebral block and
It can be given, madam, paravertebral and all, but the thing is, paravertebral or even intercostal block will not be able to serve more than 6 to 8 hours, or maybe 10 hours. Because after that,
yes,
your thing is gone. So one has to ensure that you are being having a pain relief at least for 2 to 3 days minimum, so that your lung functions will improve.
so what about the multimodal analgesia for the post-operative period?
Yeah, that's what I said. One thing, epidural plus also we have to give a multimodal, that is IV also we can give. Both. Naturally, you are right.
And Doctor, my question is to both Dr. Manjula and Dr. Gedu. Like for the
Okay.
pediatric patients, to secure the airway, we have the small tubes, and then, of course, the blockers, which are most popular. Which, I mean, earlier, of course, we just had the Fogarty's catheter. So now about this Moraro's tube, is anybody? I mean, I think they were. I mean, first, I mean, they are quite popular in Bombay. People are still using it. What is your experience? We have just seen the pictures, never used in our institution, as far as I know.
I agree,
So,
madam. Even I have not used, to be very honest. Because I
okay.
belong to
Even I
Tata
am not
Cancer.
used. I don't have
Because I belong
much
to Tata
experience.
Cancer Hospital, where the 2-3-year-old patient with a CA lung doesn't come. Honestly.
Hanji. Okay. Okay. Dr. Manjula, what about you? In cardiac anesthesia,
Even
many
we have
small
not
babies
used, but
must be
that
coming.
bronchial blockers has been used for the small kids. We have done recently that child was but 9 year old, so not very small, but bronchial blocker was used to isolate the lung in that case.
I already said, madam, from 8 to 10 years, we can use the bronchial blockers also, or DLT also we can use. But only thing, if a child is 2 to 4 years, we cannot use anything.
Then you have to really think.
And what about your experience with the Univens tube? I mean, they are there, but I really don't know whether they are, that popular or not.
No, Univent tubes are better, madam. Univent tubes, we have used
Yes.
it in our institute, and they are giving the
Okay.
good results. They
Mhm.
are giving good results. So Univent tubes can be used.
One
Okay.
aspect for Univent tube, I would like to say that the diameter, the internal diameter of the Univent, the total outer diameter is more. If you like to,
But the
if you can use a bronchial blocker inside a single lumen tube, you will get less resistance because the available
yes.
diameter for ventilation is more. Because a 4.5 or 5 size Univent tube, the outer diameter is 9. And in the corresponding case, if we put in a 8 size tube and we put in a bronchial blocker, the available diameter of the tube for ventilation is somewhere around 6 to 6.5. And moreover, the Univent tube is very costly. It is 35 to 40,000 as compared to a single lumen tube with a blocker which we can get it ETU'd and we can use again. That is just my take. That's just my take.
No, that is absolutely correct. The tubes are very costly, but we just use it by considering it is tertiary care center and we can
Yeah.
use it and we want to try it. So for the research
Yes, ma'am.
purposes, we have used
Yes,
it,
ma'am. Yes,
and
ma'am.
they have
Yeah,
given the
even
good
the
result.
Even the Viva site, Dr. Gedu spoke about the endo blockers, the bronchial blockers, but the tubes are also available. These are so expensive. Like in
It is
my
very
time,
expensive, madam. The thing
we
is,
were
it is
not able to
pretty
get it.
expensive
Akhil,
because right now
have you got it
it is
now?
very
No,
Viva
expensive. It
site?
ma'am.
costs,
No,
madam. It is
ma'am. Actually,
Viva.
the company person came, but actually, ma'am, being a private hospital, you cannot really justify that cost for that. And the other problem is that once we got it for the problem is that the camera is there on the tracheal end. So if some secretions or blood comes and
Mm.
directly on the camera, so
Loss.
that it becomes totally dysfunctional.
It
So we used it
terrible.
one, probably we used it in the wrong patient in the first time because you cannot really clean the camera. So if you are doing just for a lobectomy for a carcinoma patient, then you can put in a Viva site. But when you have to do a regular suctioning, and most of the times the Viva site, there is a complete loss of vision.
Yeah. So, are there any
Okay,
questions in the
okay,
chat box?
okay.
No,
Thank
ma'am, I
you.
don't think so, ma'am.
Thank you so much.
Thank you, sir.
Thanks for giving me such a fantastic chance. Thank you,
So
Manjula, madam.
Dr. Vimla can conclude now. I think good discussion we had
Yes.
regarding this
Thank
topic.
you very much, Dr. Gedu, for a very lucid, very comprehensive talk on the subject. And, uh, the subject is very, very important, both for the postgraduates, both in theory as well as in practical exams.
Yes,
Like, right, I mean, thoracic anesthesia, small case or big case, you may get just a patient with ICD as a short case or a full case. And then the modalities have also changed, the approach, the open thoracotomy, the video assisted, and then we have the robotics also. So it has become quite a complex affair. So very, very extremely important from the exam point of view. You covered the subject very well. And thank you, Dr. Gedu, Dr. Akhil, and Dr. Manjula, who spared her time. She was busy, but then you have been there most of the time, Dr. Jayashree, Dr. Murli, and
special thanks
Dr.
is to
Vineet, all
Manjula
those who
because
have
Manjula,
joined.
my special thanks is
Yes.
for Manjula because she was the one who incented me. Hey, Dr. Gedu, you are going to speak on one lung anesthesia. So I must give a special thanks to Manjula and of course
It,
Bimla madam. With a respect for you also. Akhil, nice meeting you.
Thank you, sir. Thank you. Pleasure
it
is
has
all mine, sir.
indeed been a pleasure and wish all of you a very happy new year.
Thank you,
No
Same.
ma'am. Same
problem.
to you,
Same
ma'am.
to you all.
Happy New Year to you all.
Yes,
Thank
Bye.
all.
See you next Wednesday. Yeah. Okay. Bye.
Thank you, ma'am.
you. Good night.
Anything else needed, you can let me know. Any other lectures also we can give. Okay. Chalo, good night.
Good night. Good night.
So thank you so much everyone for giving us the opportunity to host the session today. So with this, we are concluding the session over here for today and we hope to have you again. Thank you. Good night to all of you. Sir, I'm ending the session here.
आप ना हमारे वो कहाँ फिफ्थ फ्लोर पे जाके